Hi, everybody. Welcome to today's webinar. I'm Angela from Winona, and I'm here with two of our favorite OBGYNs, and I'm going to let them introduce themselves, and we'll get started. And everybody who's in the chat or not in the chat yet, please start adding your questions so that we can answer whatever you have for us today. Take it away, guys.
You want to go first, or?
Sure, I'll go first. I'm Dr. Cat Brown. I'm an OBGYN in Pennsylvania, and I was in the military for 12 years and then have spent the rest of my career helping to take care of women. I'm actually on call right now, so you'll notice I'm in scrubs. So if I have to suddenly run away, that might be because I have to go deliver a baby. But I'm here to answer your questions and help you to figure out if Winona might be the right place for you.
So my name is Mike Green. I'm also an OBGYN, and I'm out in California. I'm also the Chief Medical Officer at Winona. Yeah, welcome. And this is all about answering your questions. So please ask questions so we have something to answer. Typically, I sort of start off with just a little something while we're waiting for you all to type your questions in. So I just thought I'd kind of go over the process of how to negotiate Winona and get started. So, some of you have already gone through the process, some of you haven't yet, but there's an onboarding that really shouldn't take more than 5 minutes. And it's really designed to make sure that the medications that we prescribe are both safe, which is the most important thing, and then also very important, effective for you. And so the questions are everything we need to know to safely do that, and nothing extra. So what we don't want to do is waste your time, and so we don't ask a lot of superfluous questions like, it doesn't really matter if you had chickenpox when you were 4 as to whether or not you qualify for the medication. So we don't give you a giant book of stuff like when you go to a new doctor's office and have to fill that out. We really try to pare this down to what's really important. But we do ask everything we need. So you'll go through that, answer all those questions, and then I have an algorithm that generates a recommendation based on what you put in. And that was developed over about the first 1,000 patients or so. And it'll give you a recommendation of what we think will work for you. And then you can decide, gee, maybe I'd rather have this or that, and can change that around. And then once you say, yeah, this looks good, then that gets sent over to us and we review it, make sure that everything is good, that it's safe. Sometimes we'll have additional questions for you. We might reach out and ask you those questions, or you might have questions for us and there's a place to do that as well. But if everything is good, then we go ahead and prescribe the medication, and that gets sent to we have our own pharmacy with some of the smartest pharmacists I ever met, and they get your prescription ready and mail that out to you, and that usually happens within a couple of days. And that goes out by United Postal Service, good old U.S. mail, and it goes right to your house. So it's very easy and convenient, and you never really have to leave your computer except to go get your mail. So it's kind of a nice way to do it. And then we're available anytime if there's questions. We have a patient portal where you can send questions to us, and we check those questions every day and answer those for you. We'll reach out to you at about the 10-week mark to see how things are going, really sort of before that 3-month refill comes up, and see if we need to adjust the medications. And then if everything's great, then we can kind of write a year's worth of medicine where they just auto refill for you. We try to make this as simple and as easy as possible. So that's sort of the process of how Winona works and how we build that. So I think we have some questions now. Hopefully I stalled long enough.
Otherwise, the three of us are going to be entertaining each other today. No, we have questions, which is good. The first question for either of you who wants to take it is about birth control and HRT. And the question is, what is the safest or best way to transition from birth control to HRT? Can you stop birth control one day and start HRT the next?
Well, it kind of all depends on your age. I have some patients that are perimenopausal that are in their 40s and starting to have symptoms, but they still need the birth control to prevent against pregnancy. So in those cases, we can actually add in the bioidentical HRT to their birth control, and they can continue both. And then we generally recommend stopping birth control if you're on a pill by age 50. But if you're already 50 or above and you're on a birth control pill and you want to switch to HRT, you can just stop taking your birth control pill and you can just start the HRT meds. There's really no need to wean down or to do like a transition. And it's perfectly safe to transition from one to the other pretty immediately.
Great. Okay. Next question. It says, why add DHEA that turns into testosterone?
So
I'll let you talk about that, Mike.
So yeah, testosterone is often thought of as like the male hormone. And it is the dominant hormone for males, but it's also in much lower doses an important hormone for women. And testosterone is one of the hormones that's made by the ovary, and the amount of testosterone that the ovary makes also goes down as we age, just like the estrogen and the progesterone. And so if you look at testosterone levels in women, say in their 50s, and compare them to women in their 20s, it's like less than 50%. And that is can have a very big effect for women. So testosterone can be responsible for libido, and so some women find that they sort of lose their desire for sex, and that can be driven by testosterone. It can also affect weight, and it can be much more difficult to lose weight when the testosterone levels drop. It can also affect weight distribution. So weight ends up going to the middle, where it didn't used to go there when you were younger, and that can also be helped with testosterone. Testosterone can also help with mood and some other things. So it's not what we typically think about when we think about hormone replacement therapy for women, but it is important. Now, what you don't want to do is get too much testosterone, and then you start getting these sort of testosterone side effects where you get, male pattern baldness and deepening of voice and things like that. And so the nice thing about DHEA in the doses that we prescribe is that it makes enough testosterone to sort of get you back to normal female levels, but it won't push it up into those really high ranges where you can have testosterone side effects. So direct testosterone therapy with testosterone creams or shots or pellets does run the risk of pushing the testosterone too high, and you're much more likely to get side effects. So DHEA is kind of a nice way of kind of goosing up the testosterone levels just right for women to get some of those benefits back without risking some of the bad side effects. So that's why we use DHEA.
Okay, we have two questions next that are sort of the same, but from two different people. So I'm going to combine them because they're basically asking the same thing. So the question is, why bioidentical hormone versus pills you would get from the pharmacy? I think the next person asks it in a slightly different way, which is, what is the difference between bioidentical versus HRT given by like Kaiser, for example?
Yeah, I mean, the real definition of bioidentical means that we're giving hormones that are identical to those ones that your body makes itself. So there actually are some bioidentical hormones on the market that you could get as a prescription, but you're going to have to make an appointment, go see your doctor, maybe pay a copay, then go to the pharmacy, pick up your medication. Whereas with Winona, you can just do it online and we can mail the medication to you. The other thing I run into is that a lot of patients have a barrier in that many of their physicians don't feel comfortable prescribing HRT or aren't familiar with it. So, we exist really to help those patients that don't have access to be able to get HRT, especially bioidentical HRT. So that's the main difference, is just the convenience factor, but also our body cream that we compound estrogen and progesterone in. That's something that's uniquely made for each patient, and that's something you really can't get from a drugstore or pharmacy. That's something that's specifically made toward you based on Dr. Green's algorithm. And so a lot of my patients do very well with that, and they do better with that than they would have or they had in the past with other types of hormone therapy that they were prescribed previously. So I don't know if you want to add to that, Dr. Green.
Yeah, I mean, I think that's pretty thorough.
Okay.
But yeah, just because you guys don't have Kaiser out in Pennsylvania, right?
No, Kaiser is totally a California thing.
Yeah, so Kaiser is the big insurance, the biggest sort of HMO insurance company in California. And Kaiser, as a rule, doesn't do HRT, or it's like pulling teeth apparently to get the doctors to prescribe HRT. It's really unfortunate, actually. And what they have on their formulary is really very limited, and it's mostly synthetic forms of HRT or horse-derived HRT, which in my opinion doesn't work as well as bioidentical hormone replacement therapy. So I have actually a lot of Kaiser patients. Unfortunately, I feel bad for them, frustrated Kaiser patients, because they go to their doctor and their doctor goes, "Oh, Kaiser doesn't believe in HRT," and they sort of just blow them off. And it's unfortunate. It's I don't know. I don't think it's right, but it's the way it is. And so we're glad to be there and fill in that gap and take care of people when their doctor either doesn't listen to them or just doesn't believe in it, or their healthcare system doesn't cover it. So we're happy to help with that. But yeah, Kaiser is.
I didn't realize that was a universal, health system thing with Kaiser, that all physicians didn't want to,
Yeah, I think some of them will finally break and do it, but and their formulary is really, I think it's really discouraged, and their formulary is the choices they have are really limited.
Okay, we have a question about patches, but I think the way this is worded, I want you guys both tell me if you think that I'm interpreting this question right. So it says testosterone. I hear so much about it. A couple of friends are on patches. I'm assuming that means testosterone patches. Could you please explain benefits of it for women?
Well, Dr. Green talked about that a little bit earlier when he was talking about DHEA and how it gently increases your testosterone levels. So, we know that women make testosterone just as much as they make estrogen, and so it's an integral part of libido and normal sexual function, but also can help metabolism. But as far as testosterone prescribing, testosterone is technically a controlled substance because it's used in the weightlifting industry and as a performance enhancing drug, really, for athletes too. It's very limited and it's very regulated, and so it's not something we can prescribe through telemedicine. But also, like Dr. Green mentioned earlier, we don't want to give you facial hair. We don't want you to have male pattern baldness. And we certainly don't want your voice to go from this down to this, to the male voice either. So, that's why we don't prescribe testosterone at higher doses. So that's why we use the DHEA instead through our platform.
Okay, we have a question about taking a low dose, if it's possible to take a low dose of HRT. So someone who's 55 has been in menopause for 10 years, and so she doesn't have really bad symptoms, which yay for that. But she's worried about hair loss and dry skin and night sweats. So can she take a low dose just to help alleviate just those symptoms?
Absolutely. Those are symptoms of menopause. So there's a slew of symptoms that a woman can experience. And I think if we had a comprehensive list, I think the list would be 40 or 50 symptoms that we could write down, and probably some more that we wouldn't even, have on that list. But the night sweats are evidence of low estrogen, and that's something that can certainly benefit from a low dose adding back of the bioidentical hormone replacement therapy.
The next question we have is about whether or not there's a urine or saliva test to see what is needed for menopause, or is it just based on your symptoms?
So it's really based on your symptoms. So your lab test, and then there's a lot of places out there that will take your money to do a lab test or saliva test or a blood test or a hair test to check your hormone levels. But the fact is that our hormone levels can vary so much based on what we ate that day, if it's the morning or the evening, from day to day. So many things can affect that. And so checking hormone levels and replacing based on hormone levels on a lab isn't really a reliable method to determine what you need. So the best thing for us is actually to gauge your symptoms, see what your symptom profile is, treat you with a dose, and then basically tweak that dose to try to get you better symptom relief. That's the best way. So don't waste your money on hormone testing. That's something that's a big industry out there. And I feel like a lot of places that are offering that don't then have adequate treatment for their patients. I see a lot of hormone centers popping up and a lot of things popping up where they offer to do all this hormone testing, but then they don't actually have a physician who's board certified in OBGYN to prescribe you hormone therapy on the other end of that testing. So they're really taking advantage of our desperate patients who want help for their symptoms, and unfortunately aren't really helping them adequately.
Okay. We have a question. The question is, I'm 53 and my last period was last year. Am I going to have a period again?
Well, you may not. We define menopause as a full 12 months without a cycle if you're over the age of 50. Some people would argue that if you're between the ages of 40 and 50, that you might need to go a full 2 years before knowing that you're fully through menopause. You may have some spotting when you start HRT, but it should not reactivate your periods if you have completed the menopausal transition.
All right.
Dr. Green's taking the next one. He's awful quiet there.
I don't have anything to add.
You just keep going, Dr. Cat. Just
When you're right, you're
That's
right.
good. That means I'm doing good with the answers, though, right?
Yeah,
just
exactly.
knock them out. Boom, boom, boom. Okay. Someone would like to know, how safe is HRT?
So he said it was my turn. So HRT,
There you go. Your turn.
it's I'll almost guarantee you it's much safer than you think it is. HRT. So if you let's start this way. If you start with a patient that's an appropriate candidate for HRT, so that's why we have that onboarding to make sure. So assuming somebody does their due diligence and asks the right questions and make sure that you're an appropriate candidate for HRT, and you look at women that start HRT before 60, and you compare them to women that never use HRT, the women that take HRT on average live longer and healthier lives, which is pretty much what it's all about. And so not only is HRT safe, it's more than just safe, it actually helps not just your symptoms, but it helps sort of behind the scenes. It decreases your cardiovascular risk, your risk of heart attack, and it can also help increase your bone mineral density so that you don't get osteoporosis when you're older and have a hip fracture. It can also help your cognition, and there's some pretty good evidence that it helps decrease dementia. So there's a lot of health benefits to HRT. In general, we sort of don't do HRT just for the health benefits, but that's sort of a big bonus, and it kind of speaks to how safe HRT is. One of the things I remember, I told this to my wife not too long ago, and she was surprised, and I was surprised that she was surprised. HRT is much safer than birth control pills. It's a much lower dose of hormone, especially the bioidentical HRT. So, people tend to underestimate the risks of birth control and overestimate the risks of HRT. But HRT is actually, it's very safe. Does that mean nothing bad can ever happen to you in your HRT? Of course not. But it does mean that you're more likely to live longer using HRT than you are without HRT, and have a better quality of life, which again is kind of the goal. It's actually very safe for the appropriate patient, which is why you have to go through a doctor and answer the questions to make sure that you don't have something that would be too risky for you. And every now and then, I always feel bad. I had one today where a patient comes through and they have something that wouldn't be safe with HRT, and I have to tell them, I'm sorry, this wouldn't be safe for you. It doesn't happen that often, but it does. There are patients like that, and that's why we ask those questions.
We have a question that says, I'm on estradiol, but I want to switch to natural estrogen. How do I do that?
Well, estradiol is a natural estrogen. It's one of the forms of estrogen that's produced by your body. So it depends on which one you're on, I guess. I guess we would need to know specifics as far as what medication you're taking, dosage, that kind of thing.
We have I'm just reading through this to make sure I'm getting all of it. Someone says, I tried HRT, not bioidentical, that my gyno prescribed. I hadn't had a period in a year and a half, and I assumed I was in menopause. Once I started HRT, I got my periods back. I got off HRT and my period stopped again. could HRT have caused my period to come back, or is it possible I'm not in menopause yet?
I'm going to have to take this call. Hold on a second.
Okay, I'll take this question then.
Okay.
So almost by definition, you weren't in menopause, because HRT should not give you periods again if you were truly in menopause. There are a couple caveats to that. So HRT sometimes...
I have to run and I will be back. I have to go attend to an emergency.
Okay, go take care of your patient. So we are real doctors, and Dr. Brown is at the hospital on call today. So apologize for that, but I'm sure that's something important. It's not unusual for some women, when they first start HRT, it'll trigger an initial period. So it's possible somebody's in menopause, they start HRT, in that first cycle, they get a period. But it should be sort of a one-time thing. And so if that happens, it's nothing to worry about, but it shouldn't come back. If the periods continue to come back on HRT, then there's a couple possibilities. One is if you forget a couple of doses, that could also re-trigger a period. So let's say you don't have a period for a long time, you start hormone replacement therapy, you get a period, that's normal. And then you're on you continue on it, and a month or two in, you go on vacation and you forget your medicine and you miss a few days. That in and of itself can trigger a period. So that would be normal. But let's assume that you haven't missed any. And HRT is triggering bleeding that you weren't having before. That may be something that needs to be evaluated. So occasionally hormone replacement therapy can uncover an underlying problem, like a polyp, for instance, on the cervix or the uterus, that without the presence of hormone might not be detectable, but the hormone can make it show up by causing bleeding. So in general, if you hadn't had bleeding for a long period of time, all of a sudden you start getting bleeding on HRT after that first month or so, and it's not because you missed doses, probably needs to be looked into with a physical exam, probably an ultrasound, just to make sure there isn't something else going on. So that's kind of how I would handle that, if you were my patient.
Okay, we have a question about DHEA, which is just asking how much DHEA do you recommend?
So I generally start people on 25 milligrams. I found that to be a good dose for most people. I will go up to 50 milligrams if the 25 doesn't seem to be enough. I don't go beyond that. My experience is that once you get past 50 milligrams, the amount of side effects goes way up. And in general, if the 50 milligrams isn't working, higher than that probably won't help, but you're at a much higher risk for side effects. So 25 to 50 milligrams. Below 25 milligrams for most people, it doesn't really do anything. And so, there are 10 milligram doses out there, but I think that's mostly a placebo. It's just such a low dose that it doesn't seem to help. And so just to kind of let you in on, kind of the secrets of Winona, one of the things that we really make an effort to do is to keep your costs down, to keep the prices as reasonable as we can. And so one of the tricks that we do is that we purchase just 25 milligram DHEA. And so we use a 25 milligram dose, and for a 50 milligram dose, we double up on that with 2 pills. And what that does is it allows us to buy in really big bulk, which does a couple of things. Number one, keeps the cost down so we can pass that savings on to you. But also, I think even more importantly, gives us much more clout with the companies that we buy it from. So we buy like a couple million of these at a time. And when you buy that kind of quantity, we have manufacturers making it specifically for us. And so we have a lot more push to make sure that what we're getting is of the highest quality, and we can specify how we want it. We keep the capsules really small so it's easier to take and things like that. So it's all part of the process. But we, really I found that either a 25 or 50 milligram dose is really going to be the right dose for the vast majority of our patients. And so that's how we do it. Again, just economies of scale to really, benefit you guys as much as we can.
We have a question. This is going back to the hormone tests. It says, are hormone level tests performed to know if your testosterone levels are low or if HRT is truly needed?
So yeah, I'm not a big believer in hormone tests. Now, the caveat on that is testosterone. If you're doing direct testosterone replacement, that is, you're getting testosterone shots or testosterone pellets or testosterone creams, you do need to follow free testosterone levels because it's so easy to overdose people and make a mistake. And that's the only reason that, like of all the HRT, that's something that you would need to do. We don't prescribe direct testosterone, and with DHEA and 25 to 50 milligrams, you're not going to overshoot, so that's really not necessary. The problem, as Dr. Brown explained, is that particularly estrogen and progesterone levels are sort of all over the place from day to day, throughout the day, throughout your cycle, and they're really variable. And checking a hormone level at one point in time really doesn't tell you anything about treatment. It's really not helpful. This is something that's based on treatments. I like to talk about, I'm on blood pressure medication. My blood pressure medication is adjusted based on my blood pressure, by my symptom. Nobody does a hydrochlorothiazide level to see if that medicine needs to be increased or decreased. We check my symptom, which is my blood pressure. And similarly to HRT, we don't need to check the levels of the hormones we're giving you. We know they're working by the symptoms. It turns out your body is a much more sensitive assay than any lab test. So your body tells us if we're giving you the right dose or if you need it. So if you have these cluster of symptoms that we know is treated with hormones, then you'd be a good candidate for hormone replacement. And then we give you a dose that should be about right. And honestly, my algorithm gives you, it sort of errs on the side of less, because I'd rather have to increase the dose if it's not quite working than cause you side effects and decrease the dose. So usually we titrate up until we kind of hit that sweet spot. And the concept is we want to get you on a dose that makes your symptoms go away so you feel better, but not so much of a dose that you get side effects. And so if you're getting side effects, we may need to go down on the dose, which honestly is unusual because of the way we've built the algorithm. Or if your symptoms aren't going away, then sometimes we need to increase the dose. And so that's something that we do. We check in from time to time and see if you need a dose adjustment. And that's really the right way to do hormone replacement therapy. It's really the best way medically. And fortunately, it turns out to be the best way for you economically, because those tests are expensive. They really aren't necessary. So it kind of works out best that way for everybody.
Very good response. We were getting a lot of questions about this today, so prepare yourself.
Well, good. Yeah, I'm glad we can cover it then.
There's
it's very
more.
confusing, because there are companies that do nothing but hormone testing. And like Dr. Brown said, it's kind of unfair. They do the hormone testing and say, oh, you got a problem, and then they don't have any way to fix it. It's like, well, they haven't really done you much good. And they're really taking advantage of people because the hormone testing is really not necessary. And it's not the right way to do it. So, but I know there's lots of ads on the internet and elsewhere where people are pushing these tests. And so it seems, sometimes I seem like a salmon swimming upstream, but really, if you look at the medical literature, it's pretty clear that hormone replacement therapy is done on symptoms, not on blood tests.
Mm-hmm. Yeah, we get a lot of suspicion around like, wow, it's so weird that you don't require a blood test. But I think this is a big question that, people have. Even here in the group, there's another question about how do you know, I'm just going to skip to this since we're on the topic, but like,
Mm-hmm.
How do you know if you aren't doing blood tests, how do you know what amount I need? Like, how do we come up with that?
Yeah, and that took a long time to. So I'll be honest with you. In my office practice before we started this, it was sort of intuitive. I would hear people's symptoms, and I'd write them a prescription, and it kind of worked out. And if it didn't, maybe I'd have to go up a little bit or go down a little bit. And so when we launched Winona and I was developing the algorithm, it took a while for me to really get into my own brain. And it's like, what are the subtleties that's working in there that's really that sort of intuitiveness? Why am I giving some people 1 milligram, some people 2 milligrams? And I had to really kind of think it out to build this algorithm. And it took about the first 1,000 patients is how we built this. And I think we've got it. We've seen over 20,000 patients at Winona. So, over the course of this time, we really seem to have it dialed in. And for the most part, we get it right. Or as I said, it's designed to be on the low side of what should be right. Usually that's right. But if we're going to err, again, I'd rather have to give you a little bit more because we didn't quite get all your symptoms under control than cause you grief and have to dial it back down. So that's sort of the way it's built. And it works pretty well. Like I said, there was some adjusting in the first 1,000 patients or so, but ever since then, we've got it pretty dialed in. And, the other thing is that this is what we all do. And so, we do full-scale OBGYN, but we really specialize doing this at Winona of doing hormone replacement therapy. As opposed to, for instance, when I was in my office practice, I didn't do that much hormone replacement therapy because honestly, as an OBGYN, mostly what you're doing is, delivering babies, you're providing birth control, you're doing some hormone replacement therapy, you're doing hysterectomies, all this other stuff. But with Winona, we're really just focused in on this. And I think it makes us much better at it as we see more and more patients. And, it's a learning process for everybody. That's why they call it the practice of medicine, right? I'm joking, but I got my MD in 93. If I'm doing the same thing now that I was doing in 1993, I'm a terrible doctor because medicine has advanced. And so we're always learning, reading the studies, learning from our patients and our experience. And I think it makes us better, able to take care of you well. And so, with Winona, you've got people that this is really what we're doing and what we're honed in on. That was a rabbit trail. Sorry about that.
No, but I think it's we get asked this so often. I think it's a question that, whether you're new or not new, like it comes up a lot. And I just think it's a good thing to take the time to reiterate. So thank you. So we also have more questions about DHEA. Someone is asking, they're telling us they started taking DHEA a week ago and they feel a little bloated and they want to know how long does it take for the testosterone levels to balance and to see weight loss?
So bloating is a side effect that sometimes happens in the first few weeks, not just with the DHEA, but it can happen also with the other hormone replacement therapy with the estrogen and progesterone if you're also on that. And that can take, it's different for everybody. Usually within a few weeks, it starts getting better. Some people it takes a little bit longer. You can also treat the bloating itself if you can figure out what's causing it. So people have bloating for different reasons. Some people have bloating because they're retaining water. And so if you're finding that you're bloating, but also your rings are tighter or you feel sort of swollen in your legs and your fingers, then that might be water weight. Particularly if all of a sudden you popped up 5 pounds, say in a week or two, that's almost always water weight. And so an over-the-counter diuretic may help with that. That will go away, but it can take a few weeks to really kind of clear out. You might have bloating because you're getting a lot of gas, and that sometimes happens. And then simethicone, which is like Gas X over the counter, can help with that as well. Or sometimes when people first start hormone replacement therapy, they get constipated, and that can cause bloating as well. And then a medication for constipation, like Miralax, for instance, or increasing your fiber intake or increasing your water intake as well. All those things can help the bloating, but eventually your body will take care of it, and you kind of get on the other end. As far as weight loss goes, weight loss can take a while. And so if you think about it, most people have been sort of gaining weight, and then so we've got to do two things. We've got to stop the weight gain, and then we've got to turn that around to weight loss. So I kind of say it's like, trying to stop a moving train. You got to stop the train first before you can reverse the momentum and get the weight loss going. And it takes a while. So the metabolic changes that occur with the hormone replacement therapy that help with weight gain, they take a while to really take place. And so it might be, a few months before you really start seeing some significant weight loss. And the other part of the weight gain issue, for a lot of people, they aren't getting good sleep. They're waking up a lot at night. That's one of the really common symptoms of menopause. Sometimes it's the hot flashes that wake them up. Sometimes it's having to pee all night, or sometimes it's just restless sleep. And the hormone replacement therapy can help with that. But again, that can take a little while. And so first you've kind of got to get the blood levels up, then you get these changes and you start getting better sleep. Then as you get better sleep, that in effect helps with weight loss. So there's actually a really interesting study where they looked at, they were doing, I think, MRIs and PET scans, but they were looking at brain activity. And sleep-deprived people, their brain would crave carbohydrates and fat and crave calories. And it's really a survival mechanism, because if you're not getting sleep, you're stressed, you need to try to hold on to calories. And so you crave these high calorie foods. It's we call an adaptive mechanism, but sort of in present day, we don't need that adaptation anymore. And I found it really interesting as an OB, because I always knew post-call, like, I have no control. It's like I go after the fatty junk food. It's terrible. And it was great to see the study that, like, scientifically, okay, well, this explains the behavior that I've experienced my whole professional career. And so one of the things with sleep deprivation is it really takes away a lot of that willpower, that control, and your body really works against you. And so as the HRT helps you with your sleep, with improved sleep, it also helps decrease those cravings. And that also helps you lose weight, but that all takes time. So this isn't the kind of thing where 2 weeks from now you're going to be 10 pounds down. It's not going to work that way. This is really sort of a slow, steady progress, and it can take a while before you really reverse that trend and start seeing the weight loss.
Excellent answer.
Hope everything's okay.
Dr. Green. It's very validating.
Took care of the patient, and I'm back.
Good. Push.
Okay. We have a question of what's stronger, HRT and progesterone cream, or just HRT pills and a separate pill for progesterone?
Wait, what are the things they're comparing? Can you say that again?
It's HRT and progesterone cream, or just HRT pills and a separate pill for progesterone.
Well, really, when you're taking any kind of hormone replacement, the route you're taking it is just about the absorption and how your body takes in the medication. But theoretically, the dosages, depending on how you take them, whether it be pill, patch, or cream, they're all going to be effective. It's just a matter of what works better for one patient compared to another. And sometimes that's trial and error. Like I tell my patients, sometimes trying to find the right combination of medications is kind of like trying on clothes. How every woman likes a different cut, a different style. We all wear different types of jeans. Sometimes it's a matter of trying what works for you, because I've had patients that wanted to do the cream, but it just didn't fit into their lifestyle well. So they wanted to switch over to a patch or to a pill. So really those medications should be equivalent. Now there are progesterone creams that you might see sold like on Amazon or online. These aren't pharmaceutical grade medications. If they're sold over the counter like that and they're not prescribed by a physician, then it's not the same as the HRT that we're prescribing.
Good. That's really helpful too, to know, to make that distinction. So thank you. One of the questions here, yeah, Amazon. I'm going to combine both of these. They're from the same person, sort of a two-parter. So the first statement is that my mom had breast cancer, negative for the BRCA. Is this safe for me? I'm on day 10. I'm assuming that means of treatment. Not sure I'm feeling anything different. How long until I'll notice a difference?
So if you've had a family member that has had breast cancer, that doesn't mean that you're disqualified from taking HRT. I think that we're sensitive to the fact that, if your family member is a first degree relative and it had a hormone sensitive breast cancer, sometimes you worry about your increased risk if you follow genetically in their pattern. But it's some of those things that it doesn't mean you're going to get HRT. You're not going to get breast cancer from the HRT that you're taking. If you're BRCA positive, and so for the patients that are on the call that don't know what that is, that's the hereditary breast and ovarian cancer gene. In patients that have a BRCA positive status, I'm a little reluctant to prescribe HRT because they do have a baseline higher risk of getting breast cancer compared to the regular population. So if they already have a higher risk, I don't want to throw anything else on top of that. But if you just have a family member that had breast cancer, especially if it was a breast cancer later in life, after 50, 60, 70 years of age, you're still a good candidate for HRT. Do you want to add to that, Mike?
There are two really big studies that showed that as long as you don't have a genetic marker like BRCA, that a family history of breast cancer, that HRT is safe in people, even with a fairly strong family history of breast cancer. So there are two large studies that looked at that, and that was the conclusion of both those studies. So I feel pretty comfortable prescribing HRT for women that have a family history, as long as they don't have a genetic marker like BRCA, because the data, it's what the science says, so I feel very comfortable following that. And you hate to hear this, but it doesn't mean you won't get breast cancer, but if you do, it's not from the HRT. So like 1 in 8 women are going to get breast cancer. For the most part, you never know who that's going to be. So it's not going to keep you from getting breast cancer, but it's certainly not going to cause the breast cancer, and even necessarily increase your risk to a great extent, or even at all, depending on how you're taking your HRT.
The second part of the question was on day 10 of taking the meds. That can still be a little early for you to notice improvement or changes. So, your body is still trying to assimilate this medication in your regular environment or repertoire in your body, and so you just need to give it a little bit more time. Normally we like to kind of reevaluate, and I have patients kind of check in with me. We check in at the 3-month mark, because really by 3 months we should know if that medication is working for you. But you should start to notice some improvement, I think, by the end of the first month. But so 10 days is a little soon.
The next question is about what time to take your dosage of whatever you're being prescribed. But this person wants to know, do you take DHEA, estrogen, and progesterone all at night together, or what's the best practice in taking them?
It's really what fits into your lifestyle the best. I tend to recommend to my patients to take their DHEA in the morning, just because that's when our body releases its own natural DHEA, and it tends to give you energy. So I don't like them to get energy in the middle of the night. So I usually try to tell them to take it in the morning. And then when it comes to estrogen and progesterone, many of our patients like to take that at night, just because it can help with the night sweats, help with their sleep a little bit better. But then there's a small subset of patients that can actually get energized when taking any hormone. And so sometimes we just need to tweak that a little bit. So find what works for you and what fits into your daily lifestyle. Do it at the time of day where you can remember to take it accurately. Because if you're going to try to do it a certain time and try to get all complicated with it and you forget to take it completely, then it's not going to do you any good at all if you can't remember to take it regularly. So really, it's just about what fits into your day-to-day lifestyle.
I just want to ask a question while we're on this topic. Does it matter, but both of you, if you, like, say you always take it in the morning and you forget, and like you end up taking it at any random point, is it better to take it like consistently same time of day? If you miss a dose, just redo it at the same time the next day? Or is it better just to get the dose in at any point during the day, no matter if it's at the morning or when you usually would take it?
I mean, I think within reason, like if you normally take your estrogen and progesterone in the morning and you miss the dose and you realize like at lunchtime, go ahead and take it. But I probably wouldn't take it in the evening and then take your normal dose the next morning. If it's the nighttime, by the time you remember, just wait till the next day. Okay. Missing that one dose is not going to be life altering.
Right. Okay. No, that's super helpful. Okay. Excuse me. All right. The next question is about, if I start HRT now, I'm 59, am I on it forever or for how long?
Well, it really is. You want to take that? Go ahead.
Okay, I'll take that. So yeah, 59 is a funny age because people, we like to start HRT before the age of 60. But as long as you've been on HRT before you hit 60, it's safe to continue HRT as long as needed. Most people don't need this for their whole life. The average amount of time on HRT, the average is about 5 years. And I would say that women that start HRT younger tend to be on it longer than women that start it a little bit later in life. So I sort of recommend every now and then, after a couple of years, go off it and see how you feel. And that's, again, we do this based on symptoms. So you take your HRT, you feel great, do that for a few years. And then, the question is, is it time to stop it? And so choose a time in your life. Don't do it just before your kid's wedding or something. Choose a time in your life, where there's, not a lot going on, just in case, and stop it and see how you feel. And if you don't feel any different, then you're done. You don't need it anymore. Or if, I'm kind of miserable, then start it back up again. And it's safe to do that. And then you can do that every year or two, until eventually the time comes where it's not necessary anymore. And so that's a safe way to do it. It is safe to stay on as long as it's helping you. But my personal feeling is, you ought to be on the least amount of medicine as possible. And so if it's no longer necessary, that's great. And there's no point taking it.
Okay.
I also recommend that they don't try to go off their HRT in the middle of the summer, especially if you live in a climate where it gets really hot and humid. That's the wrong time to go off your HRT and to get a resurgence of your hot flashes. So I usually counsel my patients that if they're thinking about going off, let's wait till the fall or winter, because if anything, like if it's really bad, you can just walk outside in the cold and you'll feel better instantly.
Save money on the gas bill, right?
Oh my gosh, Dr. Kat's offering life hacks on menopause right now, so just everybody mark it down. That's good. I like it. Well, Californians are used to the cold, so these are good tips, Dr. Kat. Okay, question is on should I or can I stay on birth control and do HRT if you're 51?
I don't really recommend you stay on birth control after the age of 50. So, your risk of spontaneous conception or pregnancy after the age of 50 dramatically drops down. And so, our American College of OBGYN generally recommends that we discontinue birth control at age 50. So there's no reason to continue both, especially earlier you heard Dr. Green mention that the birth control hormones are actually higher doses and actually more dangerous than the HRT is. So why continue it if you don't have to?
Okay. This next thing looks like a statement. It doesn't look like a question, so I'm not really sure what to do with that. Okay. Many people.
Is that the same patient? Sorry, is that the same patient that asked about estradiol previously?
Oh, maybe that's it from up above. Okay, yes. Somebody was saying that they're on 1 milligram of estradiol.
Estradiol is a bioidentical hormone, and so if that's working for you, great. If it's not working for you, it may be that you need another dose, or as Dr. Kat was saying, that sometimes people on pills, we find they do better on creams. People on creams occasionally do better on pills. So it might be that or a patch, it might be that a different mode of delivery will help you. But if you're on 1 milligram of estradiol and it's working well for you, that's great. If it ain't broke, don't fix it, right? But if it's not working and you're still having symptoms, and it's possible you need a higher dose, or maybe a different delivery system will help you.
This is a question I haven't seen before, so I'm excited to hear what you have to say. Many people are talking about peptides versus HRT. What are your thoughts about peptides?
I'm not real familiar with this one.
So there's a couple of different things that you might be talking about. You're talking about the GLP-1, semaglutide, for instance, Ozempic, and
Wegovy.
Wegovy, thank you. It's funny because the Wegovy is actually the one that got the FDA approval for weight loss, but because of the annoying Ozempic commercial, everybody remembers the name of that one. It's a great ad campaign. But anyway, so if you're talking about those are specific. Well, those are diabetic medications, and what they found out was these diabetics started losing weight, and so they did the studies. They're fantastic for weight loss, but they don't really address menopausal symptoms. There are other peptides, quote unquote, that people use supposedly to help with menopausal symptoms. But really, when you look at the menopause transition, the root cause is that the ovary is no longer producing estrogen, progesterone, and testosterone in the way that it once was. And so my personal feeling is that if you can treat the root cause of a problem, that's probably the best way to go. And the root cause is really that you're lacking in these hormones, so treat the root cause, which is to replace the hormones. Treating just the symptoms with other medication is more of sort of covering things up rather than treating the root cause. So it depends on which type of peptide treatment you're talking about. I know that there are these compounding peptides that are touted, to treat menopause symptoms. I really don't think they do as good a job as really treating the root cause. If you're talking about the peptides for weight loss, those are dynamite, quite honestly. The semaglutide, the studies show that it works as well as weight loss surgery as far as weight loss goes. So that's a whole different thing. But you're not treating menopause symptoms. You're treating weight loss.
We have a question about an IUD and how to track what's happening. So someone has an IUD and they don't get periods, so they don't know how to track their symptoms, and they're due to get it removed in 8 months. So they're not sure what to do after that, and they're 45 years old.
Well, you may still experience perimenopausal symptoms while you're still actively using birth control, and that's okay. So I've had a lot of patients that have an IUD in place for the contraceptive protection, but then still have hot flashes or still notice, vaginal dryness or, the insomnia. And so we add HRT in, and it works, differently in your body than what the IUD is doing. So if you're worried about not being able to track your symptoms as far as knowing when you go through menopause, it's true. If you have an IUD in that's suppressing your cycle and you're not getting a regular period while the IUD is in, that's, when our hormone containing IUDs can do that. It might be hard to know when you're finally done, but if you're 45, you still need that protection against pregnancy. So I wouldn't recommend pulling the IUD and not going without anything. So you still need that protection for another 5 years.
I might need both of your help on this because I can't really understand the question. So somebody says, I find DHEA gives me headaches if I take it every day, but if I take days 15 through 28, it does not. Is this okay?
It's interesting.
Yeah, I don't, my feeling is listen to your body, and I don't think there's a big risk to doing it that way. And if you find that works best for you, it's unusual, but everybody's a little bit different. And so I'm all for, as long as it's safe, which that sounds very safe, and that works best for you, then I think that's a reasonable way to go. It's kind of an unusual thing, but we're all different. It
is, because, when we think about that menstrual hormone chart that we all memorized in medical school and in residency, our female hormones fluctuate at different times during the month, but DHEA is not something that kind of goes along those patterns. So I was thinking in my mind, is there anything at the end of the month that would make the DHEA better? Not really. But if it works for you, like Dr. Green said, don't mess with it if it works.
Okay, we have another question about testosterone pellets. We're on the testosterone kick today, you guys. I did testosterone pellets for a few years. It was great, but the facial hair as a side effect wasn't something I could take anymore. How does this program with estrogen differ from testosterone?
Well, the main difference is, we mentioned earlier that estrogen is the predominant female hormone that's produced in the ovaries. We also have some testosterone, but when you think about testosterone, it's typically the predominant male hormone in the male body. So, when we are going through menopause, what happens is our ovaries are slowly ramping down their production of the estrogen. When we're born as women, we have all the eggs we're going to have. And as we age, those eggs start dying off, and that's how we lose estrogen over time as well. And so we're giving you estrogen to replace what is lost by your body. And so it acts completely differently in the female body compared to giving a woman testosterone. The testosterone production is reduced as well as we go through menopause, but when you're doing pellets, it's a much higher dose than, the DHEA supplement that we're giving you to give you a slight bump in that testosterone back to where it was. So that's the main difference. The estrogen is replacing what's lost that your body had. Your body never had the levels of testosterone that you're getting in the pellets. It's something completely different than what your body is used to. That's why you got the side effects of the hair growth.
Okay. Our next question is about DHEA. Does DHEA and the bi-est cream cause increased appetite/hunger as the body adjusts to it?
Well, I think every woman's a little different, but go ahead.
Yeah, I was going to say, during the adjustment period, I kind of think all bets are off. So those first few weeks as the body's adjusting, sometimes different side effects happen, but that tends to sort of mellow out as the drug levels come up to snuff, and then over time become much more constant. And then really the combination of DHEA and the bi-est cream should make it easier to lose weight rather than gain weight. But the first few weeks during the adjustment period is pretty unpredictable for people, quite honestly, and you kind of got to get through that. That's been my experience. Is that what you were going to say, or something similar, or something to add on?
I mean, every woman responds differently. I mean, even when we when we prescribe birth control pills for patients, some of them get crazy appetites and some of them do just fine. It's your body reacts differently.
Okay. How long, this is the next question, how long before you notice changes with medication, and what is the approximate monthly cost?
Well, I think we talked about earlier that, we would expect by the 3-month mark that you should really start to notice some significant improvement in your symptoms. But some of the early changes that patients notice are within those first 3 to 4 weeks. They notice their hot flashes and night sweats might start to get better. Things that are more long-term, like the weight loss or the vaginal dryness, that may take a little bit more time before you notice improvement in those. But with consistent use, you'll start to see those improvements as well. And what was the second part of the question?
Cost. What is the
cost? I do not have that memorized, Dr. Green.
Okay. So it depends on what treatment you're getting, did she say whether she's on estrogen and progesterone, or? Well, I'll just tell you the price. I can just tell you the prices of everything. So the cream we can compound the estrogen and progesterone together into one cream. So if you still have your uterus, you're going to need both estrogen and progesterone. And so the most economical choice in that case would be the cream. And that, if you do it monthly, it's $79 a month. If you do it every 3 months, it saves money because we don't have to compound it every month. We don't have to ship it to you every month. And so we pass that savings on to you. And so it's about a 15% less over the 3 months. And that's $199 for 3 months treatment for the cream. For the pills, it's a little bit more if you're on both. The estrogen pills are $49 if you're doing it monthly, or I don't want to quote it wrong.
This would be a perfect time for us to have a screenshot of the price list.
We could just make a note, you guys, for the next time, so that we can.
Yeah, but it's $49 for a month, and the 3 month is approximately 15% discount off of that. The progesterone, if you need both, is $39 per month. That one I know, it's $99 per month. So that makes it, the estrogen is $119 for 3 months. The progesterone is $39 per month, or $99 for 3 months. The patches are pretty expensive. So the patches are $149 a month, or $399 for 3 months. Unfortunately, the patches are only estrogen. So you also need progesterone. Then you'll also have to purchase the progesterone pills in addition. So, and then the DHEA is $24 for 3 months. We actually only package that for 3 months. It's just the shipping costs. We'd have to make the price too much for 1 month to make any sense to cover the shipping costs. So we just do a 3 month supply for $24. So that's the prices. So again, sort of big picture, if you're doing estrogen, progesterone, and DHEA, and you're doing the cream, it comes out to around $100 a month. And that's, if you're doing all three, that's the least expensive method. Or you can save about 15% by getting it 3 months at a time.
And some of you can, I think, well, depending on if you have insurance, you can submit your FSA or HSA, expenses for reimbursement. Not everybody, you need to check with your policy, whatever you have, but some people also are benefiting from that as well.
Yeah, we do take HSA FSA cards. Those are really simple to use. For For insurance, we don't fill out insurance forms or bill insurance, but some people have had success filling out their own claim and submitting it and getting reimbursement. But some people do, some people don't. Every plan is different, so it can be very complicated. But the HSA cards are pretty simple.
Okay. We have a question. Oh, someone wants to know, what are the ingredients for estrogen and progesterone in the cream that they're using? I'm assuming it's from us.
Well, so the estrogen is bi-est. It's a combination of estradiol and estriol, in a 50-50 combination with that. And then the progesterone, if we're putting progesterone in your cream as well, then it has the micronized progesterone in the cream. Is that their question?
Yeah, I think so.
Okay.
We're going to say yes. Okay, the next question is, are the doses of estradiol, estriol, and progesterone high enough to prevent cognitive decline, heart disease, and osteoporotic fractures, and reduce or eliminate symptoms?
Well, those are all the benefits that, that's person listed are all benefits of taking HRT. And for me, knowing what dose is adequate enough to protect you against those is when I get optimal symptom control. So, if you come to me and you have significant hot flashes, your quality of life is affected, you can't focus at work because of, brain fog, you're having trouble sleeping, and we start the medication and we start to see all those symptoms improve, that tells me it's a good dose for you. There's not a magic number to get you the best heart disease protection or the best osteoporosis protection. Any HRT of any dose is protective against those things compared to none at all. So it's really about getting you the best symptom control.
Okay, someone has a question about if they're currently on an estrogen cream and progesterone pill from another company, could they start with Winona right away?
Yes. I wouldn't recommend taking 2 sets of HRT. Like, I have other patients that come to us that are already on HRT and they want to add to it. I need to know exactly what you're taking to take good care of you and to know what to give you safely. So it's really important that you don't get prescriptions from one place and then, get prescriptions from another place and you don't tell the providers what you're taking. Because there can be a synergistic effect, meaning that those medications can kind of accumulate and you could get too high of a dose than what you want. But you absolutely can switch from one to the next. Take your old medication one day and then you get your Winona meds in the mail and you could switch over completely. There's no weaning process that you would need to switch over.
The next person, this is more of a comment than a question, says they did Everlywell tests mostly because their doctor was thinking that they didn't have any issues when they have all the classic symptoms, and still nothing was helpful, even with obvious labs, just more supplements and neurotransmitter supplements. Nothing was helping, and they're looking forward to trying Winona, so that's great.
See, that's an example of that pointless hormone testing. It's like a futile effort that all these people that are taking advantage of our patients. Women are the target now of all these marketing things to try to get your money to pay for these hormone tests. And it's just really not necessary.
I agree.
And honestly, the saliva tests in particular are really not indicative of what's going on in your body, which I believe is what Everlywell does for hormone testing. None of them really work, but the saliva tests are really poor.
We have another question about switching. Someone would like to know if they can switch from their estradiol pill to Winona estrogen right away, or do they need to go off their current HRT first?
And just like we mentioned earlier, you can take one day and start your Winona the next day. There's not a waiting period that you have to take.
Okay. We had another question, which we kind of covered, but it's asking, what if you had a family member that had ovarian cancer? You're still good to go.
Yeah, assuming you don't have a genetic marker. So for instance, if you have a BRCA or a Lynch syndrome, that would be the one thing. But otherwise, that shouldn't be a problem.
Okay. I think we can take this last one if you guys want, or if you want to take a few more, let me know, because we're about an hour. So I don't want to make you stay here all night and answer more questions. This last question says, I'm confused. When is the right time to start HRT? I'm 47, stopped taking the pill due to entering perimenopause. I'm confused as my periods went from being almost non-existent when I was on the pill to really heavy periods with cramps. How do I know if I would benefit?
So the birth control pills do two things better than HRT. They keep you from getting pregnant. HRT doesn't do that. But they also work pretty well for cycle control. HRT is not going to work as well as birth control pills for controlling bad cycles. So that's kind of one of the things I always warn people about. This it's not really what HRT is designed for, and I don't think it works that well for cycle control. It works great for the symptoms of menopause, but if you had good cycle control on birth control pills and now your periods are heavy and horrible, you might consider either progesterone IUD or back on birth control pills. However, if you're also having symptoms of menopause, you might do both. So progesterone IUDs are great for cycle control. They're very low dose hormone. They're incredibly safe, and they work really good at helping with heavy periods and bad bleeding. And that in combination with hormone replacement therapy, if you're also having other symptoms of the menopause transition, is a really nice combination. So that'd be something that I would consider. Honestly, I have not found that HRT works that great for treating heavy bad periods. Dr. Rapp, would you agree with that, or your experience?
Yeah. I have noticed anecdotally, like some patients that have irregularities more in their cycle, not necessarily the flow. Like they tend to get more regular when they're on the HRT, but yeah, with the flow, if you've had heavy periods, it's not as effective.
Okay. One last question, or are we done?
I'm good. If you need to go take care of patients.
I'm at work and he's sitting in a hotel, so where do we have to go?
Okay. I just want to make sure. I don't want to keep you here past if you have things to do. Okay. We'll answer these last few. All right. So the next question is about the difference between Winona and other companies. It says so many new companies are popping up that due to this, like the one Oprah is now behind. I'm assuming that's Ever now. What is the difference? And also, what are these generic products like OptiBac or Equal good for?
So this is kind of me back on my soapbox with women being taken advantage of. So because the general consensus in the medical community in America, there are fewer doctors that are comfortable prescribing HRT and adequately addressing and treating menopause. It's this opportunistic people out there that are taking advantage, and they're popping up all these other things that may or may not be good. I think that, as a patient, whenever you see these companies, you have to really scrutinize what's behind it. Is there a medical professional that's behind it? Because there's not just Oprah. I think Suzanne Summers has something too. You go to their website and it's a special vitamin. It's, marketed, the label says, Menopure or whatever they want to call it. But when you look at the ingredients, it might not actually be, real HRT, and there might not be a gynecologist behind what you're being prescribed. It might just be a combination of vitamins or minerals or, herbal supplements, things like that. So, you as a consumer and as a patient really have to scrutinize the information out there, because these people are kind of jumping on the bandwagon because this is a hot topic. They know women are suffering and they'll pay money to feel better. And unfortunately, sometimes they'll take your money and you might not feel better. That's my opinion.
And there are a lot of companies like that. But let me just say that there are some we have other companies there. We have competitors that do a good job as well.
Yes.
And there are legitimate companies out there. And that's good. I've always felt that competition is good for patients because it makes all of us work a little bit harder to provide better care to our patients. So I ran the OBGYN for a big clinic system for a hospital, and that was always, people go, oh, this other thing's, popping up. It's like, good, that'll make us all work a little bit harder to provide better care for our patients. And so we do have competitors that are legitimate companies. and we do our best to provide the best possible care and compete by keeping our patients' costs down as much as we can. But I think we provide the best customer service. We have a great team of doctors that are super smart and personable and really care about the patients. Our patient services, our customer service, what we call patient services team, is just absolutely outstanding. We have some just really amazing people, and we really do our best to bend over backwards to provide really the best patient experience. If you look at our website, we're very, very heavy into patient education. So you'll see our journal, our blog area. We have a ton of articles there that are all peer reviewed by ourselves. So one of us will write it, the other makes sure it's good and legitimate. It's all referenced with with real articles. And we do these webinars, these live Q&As twice a month. We really do everything we can to really to not just provide excellent healthcare, good medications at a fair, as reasonable a price as we can, but we also try to treat people the way we want to be treated and do an excellent job in customer service. And I think, honestly, of course, as the chief medical officer, I'm biased, but I think we outperform our competitors that way. So there is, unfortunately, a lot of charlatans out there selling garbage. But we have some, there are some other good, legitimate companies that are also doing good work, but we think we do a little better.
I mean, the one positive thing I could say is that I'm just happy to see people talking about menopause in the mainstream media. If anything at all, maybe they are trying to make money, but maybe they're making people think, and maybe there's a woman watching TV that sees that commercial or sees that ad with Oprah come up on their social media and thinks, wow, okay, I don't have to suffer in silence anymore. Oprah's talking about it. Maybe I can talk to my doctor about it. So I think that part of it is great.
I was so excited to see that Super Bowl ad.
The Super Bowl ad.
The Super Bowl ad. How amazing.
Yes. Yeah. Never in a million years would I have ever thought there would have been a menopause commercial during the Super Bowl.
Of all the places, not the Super Bowl.
Right. Maybe the Puppy Bowl there could have been, but no.
Maybe because I was there, but that's all anybody talked about at the Super Bowl party I was at.
This is menopause ad during our football game. What's happening? But it's it's huge though. I mean, and just, especially if you're at the age of menopause, you're usually raised by boomer parents who did not talk about menopause. So, you didn't
even say the word vagina in those households,
So
just the other thing too is that if menopause was a male issue, sorry, Dr. Green, I'm going to bash on men right now. So much money and so much research has gone into the study of erectile dysfunction, right? Viagra and Cialis and all these medications have been available for years and years and years. And women's healthcare has always been behind curtains, behind closed doors, women suffering in silence. And now you don't have to anymore. Now it's more mainstream, and we just need to make sure that people know that they can speak up and they can talk to their doctor or their provider about treatments and about their symptoms, and you don't have to suffer anymore.
Yes.
Yeah,
it's all about the money. Yeah.
No, I'm there. I feel it. I feel all that. That's great. That's really good. Okay, what else? We have a couple more. I think we have 3 more. Hold on, let me find my spot. Someone would like to know, will HRT and balancing hormones help lower my cortisol levels?
Yes. That goes back to what Dr. Green was talking about earlier with getting better sleep. So when you're chronically sleep deprived and you're not getting restorative sleep, your cortisol levels rise. That's your stress hormone, your fight or flight hormone. And so when you're getting better sleep and you're more balanced, that cortisol level will go down. And that when your cortisol level is high, that can impair your ability to lose weight as well, because your body's in that fight or flight mode all the time. So overall, as your body acclimates to the medication, hormone therapy will help reduce your cortisol levels.
We have a question. Is there research that shows estriol can prevent some forms of breast cancer?
I don't know of any data specifically about estrogen. However, it's kind of interesting. If you look at hormone replacement therapy, women that have had a hysterectomy so that they're on estrogen without progesterone actually have a slight decreased risk of breast cancer than women that aren't on hormone replacement therapy. It's pretty small, so I pretty much don't advertise it that way. I kind of consider it as, well, at least doesn't increase the risk, as opposed to women that are on estrogen and progesterone. Does slightly increase the risk of breast cancer, pretty small, but there is that slight increased risk. So it's kind of interesting, and I haven't seen a good explanation for it, whether it's the progesterone that's increasing the risk or estrogen is somehow somewhat protective. I personally have not been able to wrap my brain around why that's the case, but there's actually some really good studies that do show that. And so, but I haven't seen anything on estriol, specifically decreasing the risk of breast cancer.
We have, this is interesting. I'm an African-American woman, age 69 this year, have been postmenopausal since age 55, blessed with few symptoms, vaginal dryness, using estradiol vaginal cream, and actively sexual with husband. What is the age cutoff for using vaginal cream for studies?
To me, there is no age cutoff for using vaginal estrogen cream. So vaginal estrogen is it's mostly local absorption. There's not a lot of that medication that gets into the system. And so, I would still give you estrogen vaginal cream, until the day you die. And honestly, if you're 90 and still sexually active, like, good for you. That'd be awesome. But you can still have vaginal estrogen to help keep those vaginal tissues more supple and elastic and functional. So there's no reason you should have to stop. So if somebody wants to take that estrogen vaginal cream away from you and it's really helping you, fight them on it. Keep taking it.
That's it. Fisticuffs. Here it comes. Okay. The next question asks, is HRT a good option when in perimenopause and having symptoms of low libido and vaginal dryness?
Yes, absolutely.
That's a softball question.
Yes, and yes. I'm not a doctor, and I know the answer is yes. Okay. Somebody on here really likes their doctor. Yay. Thank you for telling us. I don't know who your doctor is, but we'll take the compliment. Somebody else wants to share that they need an OBGYN for menopause treatment. You have two right here on the screen. And then do we have another question? No, I think that was our last question. Wow. We made it.
And we're not in every state in the United States yet, but we keep adding states, so right now I'm taking care of patients in Pennsylvania and Florida. Dr. Green, I don't know how many states you're up to, of how many you're taking care of now.
No, we're in 19 states. We've got, we'll be adding hopefully a few more states this quarter. Actually, it's pretty cool. So we were able to successfully lobby Idaho and get the laws changed so that we can do telemedicine there. So that goes into effect July 1st. So that's a big victory. So we'll be in there July 1st. But we are continually doing our best to add states. We cover about 2/3 of the U.S. population in the 19 states that we're in right now. So there's a pretty good chance. There's at least a 2/3 chance that you're in one of the states. But we have to do everything right and by the book, and the laws are kind of crazy, and each state has its own rules and regulations. And obviously we have to, it's really important that we do things legally and correctly.
Yeah. We have a lot of fans in here who all would like to recruit you in their states, so that's good. Everyone's shouting out their states. My state. But we have actually a couple of questions that have popped back up.
So yes, Illinois, yes, Arizona, yes, Florida, yes, LA, California. Did I miss any that people are asking about?
No, I think that's all the states being mentioned so far. And we do have a question mixed in there in the state shout outs. Someone would like to know if vaginal cream can be used in conjunction with HRT.
Absolutely. I have a lot of patients that take both. So ultimately taking systemic HRT may help your vaginal dryness long term. But if you're suffering from symptoms from vaginal dryness, taking the vaginal estrogen cream will replenish that locally a little faster than the systemic version of the same hormone. So I do have a lot of patients that start out with both, just to kind of fast track and help their vaginal health faster.
Oh, let me just say, LA, if that's Los Angeles or Lake Arrowhead where I live, that's that's Louisiana. We're not there yet.
Yeah, no, LA as in Southern California. Yeah. Yeah. So, and to the person who's saying that their gynecologist told them to do yoga and physical exercise to combat their menopause symptoms, you can come to Winona and we'll help you.
Yoga's good for you, but it's not going to work as well as hormone replacement therapy.
Yeah. So anybody else who has a question, feel free to reach out to us. If you're not already in our Winona Women's group on Facebook, you can join. It's a closed group, but all you have to do is just request joining, and it's a really great support system for anybody there who has questions and you want to be in community with other people going through what you're going through. And if you start with Winona, you can message your physicians that are here. If Dr. Kat or Dr. Green or your doctors or whomever you get, you can message them anytime in our patient portal with questions. So we're here for you. We want to just let you know that. I guess if nobody else has any closing comments, do you have anything else to add, either of you?
No, just thanks for taking the time to come out and to learn more, because that tells me that you need help and we're here for you. So
yeah.
That's what
we're going to offer a current patient webinar in 2 weeks. We're coming back here same time, well, close to the same time, 4:30, and same day of the week. But if you have anybody that you know that needs Winona, please share that with the information with them, that you're learning here, and whatever we can do to support you in your menopause process, just reach out to us. Thanks, everybody.
Yep. Thank you.
Thanks for taking the time.
Bye, everyone. Thank you.
Bye.